a mathematician to be a geek, but when I was at school in the 1970s, it really wasn't cool at all. But I went to a good school, it was a girls' grammar school, and my parents came home from a parents' evening one day and said, "The headmistress says that you're university material." And I looked and I said, "What's university?" Because actually I didn't think I knew anybody who went to one, certainly none of my family had. And when I heard, I thought, wow, I don't have to go to work for at least another 3 years. So that was good. And by the time I was about 15, my liking for maths that made me stand out as being a bit odd became really a love, and it was the only thing I was interested in doing. And that was my plan. The school obviously had me clocked as someone who should be going into medicine. And they even tried to make me do some extra biology instead of my religious education lessons. They'd realised I wasn't doing biology. They hadn't tricked. I also wasn't doing chemistry, which was probably a bigger problem, because we only had to do one science and we weren't heading for medicine or engineering. But I declined. I loved my RE lessons. The teacher didn't spend much time on the Bible, we'd done that bit. She got us thinking about difficult problems, how to make decisions, moral questions. And so I said, "I'm not doing biology, thank you, I'm stuck with my RE lessons, because I'm going to be a mathematician." Rolling forward a decade or two, the phone rang one day, and it was my rather younger sister-in-law. And she said, "Deborah, can I ask your advice?" She'd just had her first baby, and she'd gone to the clinic and they said she really does need to have her MMR vaccine. She said, "I don't know what to do." I thought, how do I answer? Do I answer as a mother? Do I answer as someone who actually by that time had been doing rather a lot of drug regulation? Or indeed as someone who knows how to make decisions? Well, we'll come back to the vaccine later because that's rather a hard problem. So I'm going to give you some easier problems to get the brain working about how to think about these things. Supposing you or your aunt was diagnosed with early stage breast cancer and your doctor said, "There's a drug called herceptin. Do you want to take it?" What would you say? What would you need to know to be able to make an informed decision? Or if you start heading towards my kind of age and you start getting hot sweats and hot flushes and drenched sheets at night, would you take HRT or would you say, "Not taking your medicine"? And for those who aren't relating to those examples, if you had a bit of problem in a certain department, would you go and see if you get some Viagra? All of these medical issues have medicines that can go a long way towards helping, but they have benefits, but, and there's always a but, they also have downsides, they have risks. And so we have to think about how to weigh these things up. So let's think about herceptin a little bit more. How do we know that it works? Different women will have very different times to recurrence. And so what we have to do is to run studies. Some women take the drug, some don't. Other than that, they all have the same very good treatment. And we collect data. And that's where I come in, because I did go and study mathematics, and I got taught some statistics, and I really rather liked it. And I discovered to my amazement that actually the people that have the best data are actually in medicine and health. And so analysing data from trials is one of the things I do. But we also need data on the downside. In this case, it came from the trial. And so what we had, the evidence that you might be confronted with is to say, well, if women with early stage breast cancer don't take herceptin, about 1 in 5 of them will have recurrence within about 2 years. If you do take the drug, that will go down to 1 in 7. So that's a definite improvement. But, and this is the but, the risk of a serious cardiovascular heart problem goes up by about 10-fold, which sounds dreadful, it sounds quite alarming. But again, if you look at the numbers, only about 6 in 10,000 women get this problem without herceptin, and it goes up to about 6 in 1,000 with it. But you still almost certainly won't get that problem whether or not you take herceptin. So what would you do? If that were the only evidence, would you take that drug? I definitely would. And that's partly because on those numbers, more women get a benefit than get the heart problems. But more importantly, I actually care more about the recurrence than I do about the heart problems, which are manageable so long as your doctor's actually watching out for them. Another woman faced with exactly the same evidence might make a different decision. And that's fine. They've got different things they care about. Now, we don't really need much fancy statistics to sort that out. Once you've got those numbers, you can pretty much make up your mind. Hormone replacement therapy is a much harder problem. And that's because there are more things to weigh up and think about. There's no doubt that hormone replacement therapy will do something about those hot flushes and make your nights a bit better. And it will do something about the thinning bones that puts you at risk of hip and other fractures. But it increases the risk of breast cancer and possibly some other cancers. In certain forms, it can increase your risk of blood clots. And so you're weighing up how much you care about your menopausal symptoms, how much you care about these risks, probably your underlying risks. And again, even in a fairly similar situation, different women can and do quite legitimately make different choices faced with that evidence. So far, I've couched this in terms of a woman making a decision. But the bigger picture, and the reason I got involved, is that regulators, governments, have to make decisions about which of these drugs should be available on the market, which is decision-making writ large. And it's only the same evidence I've talked about that's available. So how does that work? Well, typically there are committees and doctors and scientists like me sit round and say, yeah, we think the benefits outweigh the risks. And these days there are usually some lay people involved as well. But committees like that can be very risk averse. And if data starts coming in saying there are some problems, it's very easy to say, well, we should take that off the market. What's happened in recent years is that patients have sometimes pushed back and said, yes, we know there's a rather nasty risk, but actually there's also some rather good benefits. We think we should be the judge of that. And there's a whole debate about how to have much more transparent decision-making and how to find out much more systematically what patients think and value. So the easy bit of that, or the bit that's well-trodden ground, is the trials and looking at all the big data that's available to find out about benefits and risks. The harder thing is how you find out about what patients think, what methodologies you use, which patients should get to talk about it. And the work I've been involved in has given the formal underpinning for doing that so that decision-making is better informed and more transparent. So let's return to those vaccines. Vaccines are a really hard problem because often we're preventing something that probably won't happen anyway, and yet there's some quite tangible risks that might happen rather sooner. Flu vaccine, for example. That's something that I've thought carefully about, and I actually get myself and get flu vaccine every year because for me, those trade-offs are worth it. It's worth the extra time, it's worth that sore arm. And I promised I would return to MMR. What did I say to my sister-in-law? Well, I drew on my values as a mother. I drew on everything I knew about decision-making and what I'd seen in drug regulation. And I said, well, I can talk it through it a bit more, but quite frankly, if you want my opinion as a professional geek, I'd get to the GP and just get it sorted. Thank you.